So I guess it's time to get started. My name is Keila Stevens, and I'll be the MC for this presentation. Our first presenter is Ms. Peyton Dorsey. And just some housekeeping. Please check in with the QR code if you haven't already done so. We have a student volunteer who will be assisting in keeping time. The student will hold up a green sign when the presenter has 5 minutes left, a pink sign when 2 minutes left, and a red sign when time is up. Please hold questions until the end. And those on Zoom, please put questions into the chat, and presenters, if you can bring presentation, and please repeat the questions so it can be heard during the recording if asked a question. Does anyone have questions before we get started? Okay, so Peyton. Just a moment. Looks like it is.
Okay, I'm Peyton Dorsey, and my evidence-based practice topic is skill performance in nursing practice and how it affects patient outcomes. In nursing practice, there is a variability in how nurses perform skills. We are taught in nursing school to perform skills based on modern evidence-based practice, but that is not how nurses were taught 20+ years ago, because evidence-based practice is continuously changing. For example, when I worked at an immediate care facility, I was taught to administer intramuscular injections by grabbing the area of skin and pinching it and then injecting the shot. We were taught in school to use the Z-track method, which is completely different. And when I worked at the immediate care facility, they've never even heard of the Z-track method. And they were like, no, don't do that. We do it this way. The nurses, in a hospital setting, most new nurses have to undergo a new employee orientation in which they are placed with nurses who have the most experience and are very familiar with the unit. Because of this means that these experienced RNs are teaching the new nurses their way of performing skills, which could be completely different than what the new nurses were taught in school. This leads to my PICO question. The population is nursing practice, the intervention is modern teaching, The comparison is real life experiences and the outcomes is patient outcomes. The final question is, in nursing practice, does modern teaching of fundamental skills, use of models and online learning of evidence-based practice versus innovative unit experience impact patient care and outcomes? While performing my research about this topic, I found multiple types of research studies, including qualitative, systematic reviews, and randomized control trials. My first article was titled Critical Care Nurses, Knowledge of, Adherence to, and Barriers Towards Evidence-Based Guidelines for the Prevention of Ventilator-Associated Pneumonia. And this was a survey study. The results from this study showed that professional experience was shown to be associated with better knowledge scores. However, the main self-reported barriers towards evidence-based guidelines were inadequate resources and disagreement with the results, as well as lack of time, skills, knowledge, and guidance. As you can see here, most of the barriers reported by the nurses include lack of time, lack of guidance, and lack of knowledge. And you can see with this first one, maybe the last one, use of protective gowns during suctioning. That's kind of important as a nurse to wear a gown. You don't want those fluids on you. And the reasoning for not using the gowns is lack of guidance, lack of time, considered unnecessary, lack of knowledge, stored at a long distance from where needed, forgetfulness, and laziness. The second article I critiqued was titled A Systematic Review Evaluating the Impact of Online or Blended Learning versus Face-to-Face Learning of Clinical Skills in Undergraduate Nurse Education. They resulted that online learning proved to have a similar, if not improved, benefit to students' clinical skill knowledge. The third article I looked at was titled The Assessment of Knowledge and Practical Skills of Intramuscular Injection Among Nursing Staff, and it was a cross-sectional study. Their results showed that although the ventrogluteal site for IM injections is suggested in evidence-based nursing, the dorsogluteal site was the most common choice for application, which shows that there's a lack of knowledge amongst the nurses practicing, but not necessarily which method provided the best patient outcome. And you can see here with this first question, number 8, how often do you use the Z-track method of administration? And most of the nurses put never. Most of the nursing assistants put never. And you can read the other questions. They didn't use the right size needle a lot. They didn't draw up the needle or the injection appropriately. There's just a huge lack of knowledge in evidence-based practice. The fourth article was titled The Effectiveness of an Evidence-Based Practice Educational Program on Undergraduate Nursing Students, Evidence-Based Practice Knowledge and Skills. And this was a cluster randomized control trial. The results showed that evidence-based practice educational program was effective in improving the knowledge and skills of undergraduate nursing students, which leads to better health outcomes for patients. My final article is titled Evidence-Based Practice Competence in Nursing Students, an exploratory study with important implications for educators. Their results showed that nurse educators not only need to model evidence-based practice competence, but also guide students in the application of the evidence-based practice competencies for their own practice. And it was also stated that nurse educators must collaborate with stakeholders to forge partnerships so that clinical experiences reinforce the application of evidence-based competencies specifically, which means when we go to clinical and we're paired with a nurse, it's very important that the nurse be practicing evidence-based practice for us to know what's best for the patient, not just what's easier or what they've been doing for years. Because the whole point of evidence-based practice is to provide the best patient outcome. After critiquing all of these articles, it is obvious that modern teaching of evidence-based practice provides the best patient outcomes. However, there is a lack of resources to provide this knowledge and teaching to those who have been practicing for many years. In order for all nurses in practice to perform skills the right way, there needs to be educational programs implemented in the hospitals so that these more experienced nurses have the opportunity to learn modern evidence-based practice and have an opportunity to practice these skills before having to use them in everyday work. This research is important in nursing practice because evidence-based practice is something that is being taught to new practicing nurses, but not so much to nurses who have been in practice for 20+ years. This means that there is a variation in practice all over the world. If evidence-based practice is what nurses are being told is best for the patient in their care, it should be taught in the field, even to nurses who have years of experience. This can be done by encouraging educational programs that keep all staff members on the same page in each individual hospital organization. These educational programs should include online modules, checkoffs, and just in order to keep the performance up to date. If requirements like this were enforced in the healthcare field, there would be more consistency in practice, which comes across as more professional to the patients because they may have someone come in and give them an injection one day and then have someone come in the next day and do a completely different way. And they're like, who was right? Am I going to get an infection from this because someone did it different? So it's really important that we practice the same way. Does anybody have any questions? And these are the references of the articles.
Thank you, Peyton. And next we have Clara Ortega. Pull up your presentation.
Hello and welcome to my presentation. My name is Clara Ortega and I will be presenting the impact of staffing ratios on patient falls. Now, before I begin, I have a quick story that I would like to tell of why I chose this topic. So during the summer, I was a patient care tech at Northeast Georgia and I worked on a neuro-ortho unit. And one night we were severely short-staffed and we only had one tech for 32 patients. And so that night, at around 3 a.m., we had a patient's bed alarm go off. And it's customary that as soon as the bed alarm goes off, the nurses start running to the room. So the nurses were actually on med pass at that point, and so I was the only one who was able to reach that bed at that certain point in time. And so I ran into the room and I gloved up and I went in there and I was about to tell my patient, get back in bed or you're gonna fall. And he fell. And I watched him fall. And it was a scary moment because after that, it took us an hour and myself and 2 other nurses to get him back into bed. Which leads me to my question, in inpatient settings, do staffing ratios impact the frequency of patient falls? So what is a fall? Now, I'm sure that most of you already know what a fall is, but there actually is a specific definition that the National Database of Nursing Quality Indicators uses. And they state that a fall is an unplanned descent to the floor with or without injury to the patient. And they include assisted and unassisted falls that are included within this definition. And an assisted fall would basically be a patient care tech or a nurse gently helping the patient to the ground before that they can fall. Now, research shows that 700,000 to 1 million patients will fall in the United States during their hospital stay per year. And this research also shows that these falls could have been prevented, and some of them are prevented with hospitals' implementation of fall prevention programs. Things such as having patients wear yellow gowns or yellow socks indicate that they might be a fall risk. Putting fall wristbands on a patient, having video surveillance and showing the actions of that patient and when they are getting out of bed as well. And also having physical sitters in the room with that patient. Now, another definition I have before I get into my articles is something that's called NHPPD, and it's the nursing care hours per patient day. And this is the total number of nursing hours of care available divided by the number of patients in a 24-hour period. And this number is often used for staffing purposes and can determine if a unit is either overstaffed or short-staffed. And so here's an example that I provided for you guys. So if we say that there are 14 RNs working for a 24-hour period that each work 12 hours, and you divide that by 32 patients, you will get 5.2 nursing hours per patient day. And now I will be going into my literature review. So my first article was titled Nurse-Patient Ratios as a Patient Safety Strategy. And the purpose of this article was to determine whether more or better nursing care can prevent the small percentage of patients who die during hospitalizations or shortly thereafter. Now, this was a systematic review and include the author looking at 104 different articles to get what we have here. And the results that they came up with is that nurse staffing ratios have a relationship with reductions in hospital-related mortality in most studies. Now, the results for this study all these studies were limited due to a lack of studies specifically evaluating intentional changes to nurse staffing. And the reason why we do this is because if we intentionally change nurse staffing to see how bad it gets with short staffing versus full staffing, that would be against our entire nursing code of ethics. It would also be against the ethics of doing a research study as well. And this is why we don't have a lot of information on this. So overall, they found that when measured, mortality is not reduced by increasing nurse staffing, but by something the nurses do. And you can take this rather as if a nurse is frazzled and frantic because they don't have enough time to complete everything they need to do in one day because they're short-staffed, that nurse is more likely to make mistakes. And if that nurse makes more mistakes, patients are more likely to be at harm. And the relevance to my PICO question is that this study looks at how nurse-patient ratios affect patient safety. My second article is the evidence on nurse staffing ratios and patient outcomes in a low-income country with the implications for future research and practice. Now, the purpose of this article was to describe the relationship between nurse staffing and nurse-sensitive outcomes, such as falls or catheter-associated urinary tract infections as well. Now, this study was a cross-sectional design, which basically means that it analyzes data from a population at a single point in time. Their sample size, well, the entire study actually, took about 2 years roughly and had around 532 nurses, differing age, gender, years of experience, and their education as well. They also had 68,000 patients that differed in age, gender, length of stay, the admission type, as well as the diagnosis and the reason why they were there. Now, the results show that in med-surg units, when they have a decreased ratio of NHPPD, which it resulted in a higher number of total falls and higher rates of injury falls. Same thing with critical care units. When you increase the rates of falls they had a decreased rate of nursing hours per patient day. Now, when more nurses are available, the likelihood of nurse-sensitive outcomes, such as falls, decreases. And this study looks at the relationship between staffing on a unit and patient outcomes, and also mentions that higher number of nurses were proven to be effective in some cases. Now, a specific limitation for the study is that it did not analyze patient activity or characteristics. So we don't know if that patient was doing physical therapy and actually accidentally fell while doing physical therapy. Another one is that they did not take into consideration the environment of the work, of where the work environments that they were at, because that can be a significant predictor for a patient falling. Let's say that the floor, there was a spill on the floor and then the patient slipped on that and fell. That also was not assessed during the study. My third article is factors associated with falls in hospitalized adult patients. And to examine, this purpose was to examine intrinsic, extrinsic, and workforce factors that contribute to falls among hospitalized adult patients. This was a retrospective correlational design, which uses existing data for their study. Now, their sample included 160 patients, which were all on a med-surg unit. 50 of those patients fell, and 110 on the med-surg unit did not fall. And the results for this was that 25% of the falls were extrinsically driven and due to environmental hazards, and 74% of those falls resulted in no injuries, which could be due to recognition of fall risk and the implementation of fall precautions, which we talked about in the beginning. Now, patients prescribed narcotics or sedatives were 16 times more likely to fall. And for everyone who knows how narcotics and sedatives affect the human body, that makes a lot of sense. And then another one is that factors that lower the likelihood of a fall were cardiovascular disease, neuromusculoskeletal disease, higher nursing and unlicensed assistant personnel staffing ratios, and the evening shift, which also makes sense. So the study specifically looked at how nurse staffing and and how unlicensed staffing is a big factor with falls in hospitalized patients. And this article answers my question by stating that higher staffing decreases the likelihood of a fall. My fourth article was the impact of nurse staffing on quality of patient care in acute care settings. The purpose of this was to examine the empirical evidence on the relationship between nurse staffing and the quality of care in acute care settings. Now, again, this was also an integrative review, so they only looked at 12 specific articles for this research. Their results included that hospitals with lower levels of nursing staff encountered a 7% increase in 30-day mortality and a 7% increase in failure to rescue. And the rates of falls, as well as other negative patient outcomes, decreased when nursing hours per patient day were increased. Now, some limitations for this, and I find this one a little bit funny, is that the use of self-reporting questionnaires varied their data a lot, and led them to response bias. And they figured out that actually nurses convey more positive images than what is actually truthful when we do surveys. So the study looks at the impact of nurse staffing with the quality of patient care, and it is reported within the study that the rates of falls are decreased when there is a higher number of nurses staffed on the units. My last article that I'm going to be talking about today is the lower nurse staffing levels are associated with the occurrence of inpatient falls at a large pediatric hospital. Now, the purpose of this was to examine the relationship between nurse staffing levels and pediatric patient falls in a large children's hospital. The design for this was a case control study, which basically looks at two different groups and figures out an outcome, and an outcome is identified, and then it's compared to the other separate group. Now, the results for this were that 111 falls were documented over a period of time between July 1st, 2013 and March 31st, 2014. 111 falls were documented, with 36% resulting in injury, and the greatest number of falls happened on medical units. Now, the physical and psychological falls were the most common, and nurse staffing levels, particularly again on night shift, were lower in units where falls occurred. Now, this study looks at the difference between lower staffed units versus fully staffed units and how that relates to inpatient falls. Now, when looking at the synthesis of my literature, some things that I used to come up with all of these articles, and you can do this too if you really want to know more information, is that I looked at patient safety, fall prevention, falls, nurse-patient ratio, and finally, short staffing. I found similar articles through the smart text feature on the library databases, and almost every article came to the same exact conclusion that using different approach. Now, each article stated that nurse staffing greatly affects patient safety and helps to reduce patient falls. And almost every article mentioned the fact that there needs to be more research on this, and that there is not enough research to give a definitive answer of yes, that nursing nurse staffing does have an impact. So we need more research. So why does this matter? Why am I presenting this to you guys today? Well, patient safety is our #1 priority as a nurse. As teachers nurses, it is our duty to maintain patient safety. My PICO question highlights that the impact of staffing ratios is not only important to patient care, but to the future of nursing practice as a whole. So how can this be implemented in nursing practice? It's by increasing or adjusting nurse staffing levels to improve nurse-sensitive outcomes. And that's kind of an easy answer to say, but it's also a very difficult answer to achieve because there is a limited number of nurses and a limited number of nurses who want to specifically work in medical surgical units. A lot of nurses and nursing students really want to go out and do labor and delivery or do ER nursing or do something else. And so managers should instead assess the characteristics of nurses. So whether that be their education, whether they be if they have certain certifications, or whether how long they've worked on that specific unit. They should assess their work environments as well and those specific patients. And with all those factors combined, then you can assign that nurse to that specific patient, knowing that you're giving that nurse a safe patient for that shift. And that is the end of my presentation. Do any of you have questions? Yes.
Did any of the literature you reviewed suggest what a safe NHPPD might be? Or is there just not enough research
Actually
to
did
conclude?
not, no. And I know that because we were in a leadership class actually as us as seniors, and something that we covered is staffing and how we would do that. And that's actually how I figured out that equation is we had to write that equation to figure out whether a unit was short-staffed or overstaffed. But it did not in any of my literature state what was a safe NHPPD, and I don't know if there really is a certain standpoint of one that I know of. Anyone else? Oh, awesome. Thank you.
Next, we have Ellie Alberon. Get it pulled up.
Hi, everybody. My name is Aurelie Alberon. I am a senior nursing student, and today I'm going to be presenting language barriers in healthcare. So before I start, I want to do a little activity with you guys. You can participate if you want to. You don't have to do much. All you have to do is close your eyes and listen. So I'm going to be saying like quotes of a patient who doesn't speak English and they're in a hospital setting. Okay. So these are their thoughts throughout the day as they're admitted to the hospital. So close your eyes and just listen and put yourself into that perspective. I have been in this room all day with no updates. I wonder if everything is okay. Why is this machine next to me beeping nonstop every time I bend my arm? My pain keeps getting worse. I wish my nurse would stop by. I don't know how to get in touch with her. Oh no, why are all these people running into my daughter's room? What is all this machinery for? Are they gonna use it on my daughter? Is my daughter gonna be okay? I am so thirsty. Why won't the nurse give me something to drink? Why are they sticking me in this big weird tunnel? Well, whatever it is, I'm gonna be holding on to my gold cross and keep praying, hoping that everything will be okay. Desde que esa enfermera me dio esa medicina, no me siento bien. Me duele mi brazo, siento comezón y náusea, mareado, y la garganta se me está cerrando. I will translate. Ever since that nurse gave me that medication, I don't feel well. I feel itchy all over, nauseous, dizzy, and my throat is closing up. I can't breathe. You can open your eyes now. These are patient experiences that they have in the hospital setting who don't speak English. So a little background on me, I am a first-generation college student, daughter of immigrant patients. And when I was a young child and I would go to the doctor's office, sometimes my mom wasn't able to communicate to the doctor, the physician, the nurse, why they were here. And for that reason, I am doing this research and wanted to kind of start off this presentation with giving you a little insight on what that perspective is like. So currently 1 in every 5 people in the United States have a low English proficiency, meaning that they are not fluent in English. And it is detailed by the Title VI of the Civil Rights Act of 1964 that every federally funded health institution must provide interpreting services for these patients. However, due to financial restrictions, this might not be always the case. It might not always be enforced. So with those limitations, and knowing everything that we know in nursing, are healthcare outcomes affected by language barriers in Spanish-speaking populations? And so I've listed some articles here. I'm just gonna go through with kind of some of the overarching themes that I found in these articles, and then I wanted to share that with you. So my first article, an exploratory analysis of patient-provider language concordant home healthcare visits. This article really talked about if the provider and the relationship between that healthcare provider or that physician's physical therapy or nurse that was doing a home visit, how many of those relationships were Spanish fluent? Like, was there a fluent communication between the patient and the provider? And it wasn't always the case. Sometimes they would have to use an interpreting device, like an app or a Google Translate or something to help them translate to the patient. And it concluded that ensuring that language concordant encounters happen across all any healthcare setting is an essential strategy to increasing access to better outcomes and caring for these patients at earlier stages of their disease process, reducing the readmission risk and improving the transition as they go through back and forth through healthcare system. Another article that I looked at was differences in patient experiences between Hispanic and non-Hispanic white patient across hospitals. And here it really talked about, it illustrated patient experiences through hospital settings, those who were fluent in English and those who weren't. And this was measured through surveys that the hospitals do to see how well they're doing their job. And both article 2 and 3 kind of grasped on this, and something that influenced how the patients responded was also like their cultural background, like where they came from. Just to kind of put it in perspective, many of these Spanish-speaking patients come from other countries that a hospital or a healthcare visit might not look like the fancy buildings that we have in the United States. So if they come from a rural town in Mexico, the doctor's office might just be a desk and then just doctor and a stethoscope in a blank room next to the farmer's market. Whereas here we have these nice fancy hospitals and nice equipment, very nice lighting, AC and all that stuff, versus in, like I said, in small rural towns from where they're from, that might not be the case. So already with that, by then coming to this country and having that experience, it's gonna increase like what their patient experience is, and like, oh wow, like this is very great from compared to what I had at home. So that influenced, I guess, the Spanish speaking patients responses in the survey versus someone who was raised here in the States. Their standards might be a little bit higher, but overall the healthcare outcomes are influenced by that patient experience, by how well they felt they were treated while they were in their stay. Another literacy that I looked specifically at type 2, this is my article 4, health literacy and patient reported outcomes. This is a cross-sectional study for Spanish speaking and non-Spanish speaking patients with type 2 diabetes. Here, we were looking at diabetic patients, specifically adult patients who were receiving education on how to better manage their diabetes. So when you have diabetes, your blood glucose is always up. So meaning you can't have a lot of sweets and you have to constantly pick yourself to see how your sugar is doing. And the way that we're measuring in the study is we're monitoring their lab values such as their A1C. So A1C is a lab value that we look at to see in the time span how well has this patient been managing their diabetes. And those patients that were Spanish speaking had worse outcomes, meaning like their A1C was a little bit higher than those who were English and understood the patient education. Another thing too was that these patients that are not from the United States have a different diet. And so there's not readily available a Spanish speaking dietitian or someone who's a translator and educate them like, let's specify this to your cultural backgrounds. For example, like I can give you this insulin day in and day out, other medications to help you monitor your blood glucose. But after my visit, I might go hit the taco stand and get a lot of extra spicy sauce, a lot of like Diet Coke, flavored water, like agua de horchata, Jamaica, and all this stuff. That diet is a huge factor into how well that diabetes is going to be managed. So really grasping on to it's not just the language, it's also the culture. Like, where am I coming from? What is all of that? How is that going to be integrated into my plan of care? My last article that I also wanted to integrate, the battle of managing language barriers in healthcare, specifically looks of mothers of children going to urgent care for like pediatric care. Something's wrong with their child and they need some help. And it really did focus on how they felt going through the healthcare and their approach to it. And many of them felt at times misunderstood and sometimes even discriminated against. In instances, they feared coming back because they felt like, well, I'm not going to get the care that I need for my child. And just frustration in a sense, because I'm not able to communicate to the nurse like, hey, my child like has been coughing for like a long time. There's a fever. What do I do to help them? And the mother typically goes back to the place where there might be an interpreter. Like that's another thing that affects like, where am I going to go seek care? Where is there an interpreting service and where do I feel comfortable? So it really came down to, it's not just the language, it's also like, where do I feel comfortable and where can I feel like I can establish a relationship with that provider? So that's another thing that was also, that came up, that it's not just about me being able to communicate, but me also being able to trust you and put my care in your hands. So like I mentioned, the overall arching theme and these articles that I presented depicts really like a battle within Spanish-speaking populations in the healthcare system. This is a system that is supposed to provide accommodations, but might necessarily be all the case for every patient. The articles also considered factors such as socioeconomic status, levels of education, and the support system that they have at home. Such factors influence healthcare outcomes in these populations as well. There might be a language barrier, however, non-establishing a trusting relationship with their primary provider might be a more significant barrier. A trusting relationship will allow patients to truly engage and participate in the healing process, leading to improved health outcomes. So relevance to nursing. Language barriers influence a trusting relationship between Spanish-speaking populations and the healthcare provider. Healthcare outcomes are more influenced by the individual's self-efficacy and life factors such as socioeconomic status, education, and support level at home. And the relevance of all of this really is that it humbles a nurse who will one day interact with a patient who comes from a different background and speaks a different language to theirs. In nursing, there's always an emphasis on enhancing patient comfort. Understanding the role that language plays in creating a trusting relationship with the patient is critical for nursing. Cultural competence is essential in nursing. As a nurse, the forefront of providing care to patients at bedside and in the community. So here are some of basically of why is this relevant to nursing? Why is this important? Why is addressing language very important in nursing? So again, it goes back to increasing that mutual respect between the patient and the doctor. And of course, it's going to improve that outcome. It's going to keep that diabetic patient from coming back. It's going to keep that mother from being worried all the time about their child's care. And even though there's still a lot of research to be done on this topic, and there's still like struggles with Spanish-speaking patients that seek care, there have been attempts to break this barrier. And you do see these things currently in hospital settings or in urgent cares. So there's on-site interpreters, like you see here. And there's also iPads, tablets that they bring into the patient's room. On the other side, there's a person that speaks their language. This is for any language, not just Spanish. And also what you see here, the doctor and the patient have someone on the phone, and they're kind of both talking simultaneously to the interpreter to ask questions, to get more information for their assessments. And so really and truly, when you go into the healthcare setting, so to a hospital, let's say you go to the ER right now because you're having a lot of chest pain. Well, we're going to ask you a lot of questions to get in more details on like your visit. So why are you here? When did this pain start? Are you currently on any other medications that I should know of? Do you have any other relevant history that I should know of? Like, is there cardiac issues frequently like in your family? Because that's going to affect how I'm going to move forward with my treatment. So it does affect healthcare outcomes, because in the articles, it also stated that like, patients would come back again for the same issues. And a huge part of nursing is education. So I'm going to educate my patient on what they can do outside of the hospital to keep them from coming back. Because as much as I like them, I don't want to see them often because something is not right. So this is what you do to fix it. So I'm going to give you this medication, but make sure you do X, Y, and Z at home so that you don't come back. And in the beginning, I kind of went over some scenarios. So something as simple as the person that was going through the tunnel and was holding on to that gold bracelet. They were going through a CT scan to see, like for example, like if they had a stroke, I gotta look at the brain to see where that bleed is. And you can't be holding on to that gold bracelet because it's like a huge magnet. It's gonna go right through your hand and it's gonna rip it. The patient at the end that I stated in Spanish, that patient was gonna have an anaphylactic shock. A huge, horrible, worst allergic reaction that you can experience from a medication. So they need to get in touch with the nurse stats, but they can't, they don't speak the language. And so another thing that I mentioned in this presentation was a trusting relationship with my clinicals in the labor and delivery unit. I was really impressed by some of the nurses, how they have taken the initiative to learn a few phrases, and they would introduce themselves. And this is more specific, I guess, to like nursing, but introducing yourself, like, hi, my name is such and such, I am your nurse, goes a long way. And it's kind of like the first step to, build that trusting relationship and breaking that language barrier. So that's all I have. Any questions? Yeah. Good.
Next, we have Nancy Bergen Ortiz.
Good
Good morning, everyone. My name is Nancy Virgin Ortiz. I'm a Piedmont senior nursing student. Today, we're going to be talking about the effectiveness of team care approach versus primary care approach in acute care settings. So how many of you guys have a job where you have to work together with another individual? And how many of you guys that raised your hand know how your day is going to be like that with that person or without the person being there for you? Well, that's exactly the day that a nurse consists of. If you're clocking in at 6:45 a.m. and you're notified that there's no tech, there's no secretary, there's no transporter, what should a nurse do? Well, the best thing that a nurse can do is get with someone else, majority of the time is a nurse, and be like, hey, I'm going to do this, I'm going to transport this person, I'm going to change this person. Can you do this for me? Well, sadly, the story is that not always nurses work in teams. Not always do they have someone. Not always do they have a transporter. Not always, unfortunately, have a tech. So what happens? We have medical errors. Medical errors, patients have a 1 to 300 chance of being harmed while in the hospital. Patient harm is the 14th leading cause of global disease burden. Unfortunately, it's the 3rd leading cause of death in the United States. And I believe that teamwork can really reduce this. We can help our nurses because at the end of the day, they're the ones that fall for the, they're at risk of losing their license. They're the ones at risk because they're the bedside nurses. And we can help them by helping them establish teamwork care. So the purpose is to emphasize the importance of team care approach rather than primary care approach in acute care settings to improve healthcare workers' moral and patient outcomes. So I ask you, in acute care settings, what is the impact of team care approach versus primary care approach in acute care settings that affect the moral and patient outcomes? P being the nurses in the acute care settings, which is the population that we're looking for, I being the interventions, which is the team care approach, and C comparing it to primary care approach, and O being the outcome. So how effective this patient care is, and also the job satisfaction, which is what we want. We want more nurses to work, more nurses to be happy. So my first study, acute care nurses' perception of leadership, teamwork, and turnover intervention and patient safety. This was a mixed method study. It looked at 185 out of 245 nurses. It was a qualitative semi-structured interview data with 50 participants. The results included that 74.1% of all the participants perceived the lack of support for safety and for most senior leaders. That means that these nurses never saw the nurse managers. The nurse managers were in their offices sending emails. They didn't know what was going on. They didn't know that they didn't have a patient care tech. They didn't know that a patient had fallen. So this caused an increase of employee turnover. What does that mean? That means that all of our patients are at risk of healthcare acquired infections and medical errors. They're having nurses quit because they don't feel the support that they needed. Limitations, it excluded nurse managers. They were part of the survey. It excluded patient care techs, nursing assistants, and physicians. It was a convenient sample recruiting participants from community hospitals, but the strengths included that it was a large sample size, approval towards an enhancement of senior leadership role, and the majority were nurses precipitation. My next study, examining the average scores of nursing teamwork, subscales in acute private medical ward. So 45 part-time and full-time nurses were interviewed in acute private units. It was a quantitative descriptive research that used the NTS to measure 5 of the subscales that included trust, team orientation, backup, shredded mental model, and the team leadership. So 90% of the participants agreed on the need of improvements in these areas. The strengths, it focused on the nurse's perception in the descriptive survey. Limitations, it was a private and local and large hospital. It was kind of had some convenient sampling. It was based on the NT rather than the observation from the team members. And my third study, teamwork and patient care teams in acute care hospitals. There was 200 out of 600 participants. 102 were nurses, 46 were RPNs, which are like practical nurses, 15 unit clerks, and 10 personal support workers, and 10 others. So what's the result? The staff members scored better in critical care units versus inpatient surgery units, according to the NT survey, and inpatient units scored the lowest in concepts of team leadership and mental model. 81.9% of the participants had the intention to leave the current position in the following year due to poor leadership and teamwork mechanisms. And most of these patients expressed the need for change because they didn't feel safe in their workplace. They didn't feel safe taking care of a patient by themselves. And some limitations and strengths. Limitation, it was supportive of opinions and ideas, but those opinions matter, and we want to know what our nurses need, and we want to hear them. Units involved included adequate staffing, and there was less male nurses and physicians. We want to have the majority of the people included in these studies. We want to hear from everyone. The strengths, it was a large sample survey. The importance of adequate staffing was repetitively stated throughout the whole study. So improving team performance and patient study on the job through team training and performance support tools was a systematic review, a journal that I found. It consisted of 20 articles that were selected between 2008 and 2018, so a 10-year period. It included results of the Team Steps program, which is a new program that many facilities across the country are using. They're not all the same, but they specifically focus on building teamwork mechanisms in the hospitals. 61% to 82% found that it was more beneficial in making patient-related decisions within a period of 1 to 3 months. So these people are not trained long enough, but they are given the specifics of how to have somebody be your wingman, which Northeast Georgia is developing this new thing that's called the wingman. So you have a nurse while you're in lunch or you're out of the unit that will help you if you're called, if your patient's harmed, or if your patient unfortunately codes. Limitations include the descriptive and qualitative articles. It was a Coxsackie experimental design, and some studies were used to control and compare the groups. The strengths that the article was analyzed, it was an evidence-based practice study. Another journal, the cross-culture validation and psychometric testing of Norwegian version of the STEPS program. This was a questionnaire, consisted of 624 professionals, and for the first time we had physicians. There was 110 of them, 405 registered nurses, 24 midwives, 49 ANS, which are different types of nurse, and the psychotherapists, which were 19, and occupational therapists, consisted of 7. And this was divided between 2 hospitals. 247 healthcare nurses responded with a majority vote of 69.6% stated that they strongly agree for improvements on the TTAQ questionnaire, which is their kind of teamwork mechanism, and they wanted to change it to the STEPS program. In categories such as team structure, so they wanted to change the way that their teams were set up, their leadership, the situation monitoring, and mutual support and communication. They wanted changes in those areas. The strengths was that it was a large sample size, had input from 2 hospitals, and physicians were included for the first time. Limitations, it retested it in less participants the second time, and there were some concerns for biases. So this study basically was done again, and we had less people because they felt like they weren't being heard the first time. My last one, qualitative systemic review of multi-professional teamwork and leadership training to optimize patient outcomes in acute care hospitals settings. So this included intensive care units, pediatric intensive units, and trauma centers, the emergency department, and stroke units. The participants included physicians as well, nurses, respiratory therapists, and patients. Patients had a say-so in this study, which I found very interesting because we always want to hear about how their experience was at the hospital. Overall, 12 studies were used to investigate the aspects of teamwork in leadership in acute settings. It was a relevant paper that was established for a 14-year period. So it started in 2000 and they ended it in February of 2014. So the results, the teamwork training intervention made a significant difference in patient outcomes by increasing communication skills, time management, decreasing the workload, and improving team skills. Some of the limitations and strengths. Limitations, population consisted of a mixture of patients, events, hospital admissions, healthcare personnel, and teams. But the units didn't specify the specific population that was involved in the study. The resources reviewed differently across the world. So this study has been translated in numerous languages. The strength, it was a worldwide systematic review, and it focused on acute care units, and it involved patients. So the synthesis, common themes noted among all six resources was the importance of teamwork, effective communication, leadership in acute settings to improve patient outcomes, and job satisfaction. More importantly, the absence of teamwork in most hospital settings has affected how patients are admitted, cared for, and discharged. So you may ask, how is this relevant to me? I'm a patient care tech. I worked in a COVID unit. We were spoiled to the point that we had pandemic partners, which consisted of people from different areas in the hospital that helped us. We were spoiled. Once they left, our hospital had more falls, more infection-related healthcare complications, and we're starting to see that patients are unsatisfied. They're asking to be discharged early, or they're asking to be transferred to a different unit. So teamwork is a big part in healthcare systems, and it's one of the biggest things that nurses are unfortunately face every day. So I say that we hopefully can make this change soon enough so we can help nurses to know that they're not alone, because teamwork divides the task and multiplies the success at the end. And these are my references. Anybody have any questions?
Although you said, I mean, your goal is to work as a team, you feel staffing-wise, you have enough to do so?
I think if we built a teamwork, it should be looking at different perspectives. Whether it is we have the enough staff, whether it's picking up your tech and being like, hey, we have the same patients, let's go into this room and do everything together. Or whether it's we don't have a tech, we don't have a secretary, what do? We get all the nurses and we see what can we do? Can we call more people in? It's working as a team that makes the difference rather than working by yourself. Anyone else? Thank you.
It's 3:10, correct?
Correct.
Okay.
Yeah.
have everyone. Okay.
Just because we're gonna use this one because that one is black.
Where's my?
Okay.
All you have to do, where I stood, basically, there's a lot of 15 minutes. As soon as you- So I just have in mind, you hold there, make sure you make eye contact with them. I just kind of said. Yeah. So I felt like start doing this. You know, like, it is kind of-
If it's raining.
You're golfing. What's your name? Y'all the big set? Yeah. So here. Well, it's funny because no one pointed it out. Whatever. We'll stay on, no fine. Doesn't make any difference. How are you doing? I'm okay. I'm actually getting close to stuff, although we had problems with it. And it's long, so I was in the back, so. Oh, we already did the bridge. So, yeah, I did that yesterday. Okay, so I'm gonna make a note. to not have the word Fisher. You're in the room over there, man. Is it bad? Well, I think I'm gonna. Sorry about it. Yeah, we can see it on the screen. We can see it. Yes. Well, we will have the black where. Yep, those are only hiccups for the day. Okay. Yeah.
I put the number 2 letters on the-
Okay. Yep. Okay. Okay.
All right, so that's what you want here. So, yep. She got everything.
These are
Everyone be sure to scan the QR code if you haven't. We'll be getting started. My name is Keela. I'm the NC for this presentation. We have a student volunteer who will be keeping time. The student will hold up a green sign to the presenter when 5 minutes when there's 5 minutes left, a pink sign when 2 minutes are left, and a red sign when time is up. Our first presenter is Wade Kreider. And is Wade here? Wade? We've got like well, okay,
I didn't know if it was.
we're tied now.
My bad.
It just turned, so
All
if
right.
you're ready,
I'm good.
okay.
Y'all ready? Okay, so, when y'all first got the email, it said, why literacy should be into the classroom. I decided to narrow that down because it's a very broad topic. So I just decided to stick with educational theorists. Therefore, it'd be easier. So today I'm going to be talking about 2 educational theorists and their methods, strategies, and ways of taking their children into the classroom. So the first person we have is Liv Vygotsky. He was a Russian, he was born in Russia. He is a Russian educator. I'm pretty sure in the, I want to say the 70s or 80s, I'm not sure. But he had something called the zone of partial development, which refers to the range of abilities an individual can perform with the guidance of an expert, but cannot perform on their own. So the sort of the dummy-fied version of it would be a student in the classroom which would need help doing assignments in the classroom. So the teacher would be shadowing the student. He also wanted child development through social constructivism, which was cognitive development and social interactions, which would be from student to student or teacher to student. Either way, we get the students to be communicating more in the classroom, which would better help the students better off. We also wanted the students to challenge, we wanted to challenge the students in the classroom so therefore they're keep making new goals and therefore they can crush their goals and make new ones. We also wanted students to have an active voice. So this would be them, once again, going back to the social constructivism and interactions, one of them to have an active voice so they could be more communicative towards each other, towards this teacher as well. And then you also wanted them to solve through problem solving. One of the methods that he used was called scaffolding, which is a teaching method that involves gradually shedding the instructor's assistance as students increase the understanding. So what that means is, I just don't know if you can see this chart pretty much, but so the teacher would be the model. She would hand out, or he or she would hand out an assignment to one of the students. The teacher would guide the students throughout the assignment. But throughout the assignment, the teacher would gradually step aside, helping. So therefore, the student can gradually release on his own. So therefore, he can learn the material better without the teacher trying to hover over him and try to do the work. Which overall leads to the student's independence in the classroom, so the teacher doesn't have to shadow him over everything into the classroom. He did this through sensory, graphic, and interactive. Sensory would be physical and visual elements. As you can see in this classroom, there's a poster on the wall, and another one in that corner. What should be better, what should be good for the students is the visual see element. It'd be better for them to take a test so they can remember it. Once again, graphic organizer would be like T-charts, visual diagrams, and then interactive would be collaborative learning, which would go back to the social interactions between teacher and student. And then the second educational theorist I have is Jerome Bruner. He was concerned with how knowledge is represented and organized in different modes of thinking. He did this through 3 modes of representation, which is action-based, imagery-based, and symbolic representation. The action-based, which would be physical actions, which would be in the history classroom. I'm a history fanatic, so I would use history as an example. It would be debates or role-playing. So it would be one of my classrooms that I've been in, it would be, let's take World War II for an example. It would be the Allied powers, Great Britain, USA, France, and then those would be the big three. So they'd have like 2 or 3 students representing them, and then the Access Powers would have them representing 2 or 3 students representing the Access Powers, and you would debate. But you would debate over the Treaty of Versailles, which ended the war. So that would be a good debate to get the students into the classroom. It become more communicative between teacher, student, and student. Next one would be image-based, once again, pictures for the students to remember the objects or the material in the classroom. And then symbolic would be language-based, which would be words, symbols, or phrases that the teacher would give the students for them to remember. One that really worked for me when I was in high school was north, south, east, and west, which would be never eat soggy waffles. That would be one of my representation of that. It's always worked for me. Next one, please. And then he used something called the spiral curriculum, which refers to the curriculum design in which key concepts are presented repeatedly throughout the curriculum, but with deepening layers of complexity and or in different applications, which would be prior knowledge, increasing depth, or silical. Silical would be students return to the same material, so it would be at the beginning of the lesson. Or my bad. It would be so the teacher would have a lesson, and then she would go through the lesson, and then so the teacher would go through the lesson, and then they would go back to it to make sure the students are understanding the material and making sure that they're retaining it. The next one would be increasing depth, which would be a deeper level and more complex, which would be, once again, the students should go back on it, but when they go back on the material, there'd be more information, more facts, more things to learn about. And then prior knowledge would be built upon recent material. So once again, the teacher would go through the lesson and then go back to the beginning, but then once again, it would build upon prior knowledge, which would be pre-tests. The teacher would do pre-tests to see what the students know. So that way the teacher don't have to teach certain things that the students already know, so they can jump into a new subject, which should be better for the teachers and the students as well. Please.
Oh,
This spiral model right here, I don't think y'all can see it, but at the bottom, it says difficulty on the arrows, and at the top, so the bottom difficulty would be like beginner stuff, and then the top of it would be like AP classes or like the hard materials. So at the beginning, it would say new content, once again, which would be the silical, and then it'd be revision, which would be increasing depth to make sure the students are knowing it. And then the top would be mastery, so that where the students knows the material and they can move on to the next topic during history or the next time period, depending on if the teacher thinks the student is ready. Now you can click next one. And then these are the references I used for this whole PowerPoint, including the educational theorist Liz Vygotsky and then Jerome Brook. Is there any questions? Thank you for your time.
Next, we have Morgan Calhoun, Austin Vaughn, Lakin Stiles, and Shaylin Sutton.
Good morning, everyone. I hope that you like math because today we're going to talk about how math relates to your life, how to help people that don't like math to like math, hopefully. And then we're also going to talk about how math has changed over the past 10 years. If you could all pull out your cell phones and pull up the regular camera, we're doing a survey. Scan this QR code. And then while you're taking the survey, Austin is going to talk about how math relates to you.
So I don't want to spoil your survey taking, but I do hope that a lot of you do have some negative perceptions about math because this is really for all of you that dislike math. We really want to talk about why this even matters because to a lot of Americans, we consider reading to be really important, at least literacy itself we consider really important, but it's perfectly acceptable to say, I'm not good at math. I can't do a lot of the basic functions in math. It's all right if you're slow on these things. And we really want to explain why that's actually detrimental thinking to the entirety of culture. Because even if you go into a field that isn't necessarily math centric, it has a lot of benefits to it. So we're going to be covering two major research driven points. And the first one is correlative economic success. And the second is potential effects on brain development. So a lot of times when educators and even the government itself are trying to predict what a rising generation of students are going to do after they graduate, a lot of times what we look at is reading scores and math scores, and those directly predict how well people are going to do economically. It can even predict really incarceration rates, which is concerning. But a lot of times we look at those things together, or we just look at literacy. But I wanted to isolate math in my research. And this is just one example from the research on a specific demographic. A study in men found a single score deviation, a gain of 1 for math achievement at age 16, predicted 14% more earnings at age 33 and approximately 18% more earnings at age 50. So is this mere correlation or causation? And that's what we want to talk about by viewing the entire context of the research. Are they just doing better because people that are more well off are just better at math because they have the resources to be better at math? Or is it that being better at math and learning more math actually improves your economic success later on? So another study examined student background's relation to their perceptions and success. Both interest and perceived ability in mathematics were significantly related to improvements in mathematics grades over time. Economic disadvantage to mathematics achievement were not significant. So what that means is, even though an economically disadvantaged student, they may not have the same gains as a higher economic student, there's not necessarily a disadvantage that they're starting with there. There's nothing detrimental in being economically disadvantaged that's going to prevent you from learning math. Children who were eligible for free or reduced price lunch at school reported higher perceived costs of learning math, which in turn predicted lower academic achievement in math. However, economic disadvantage did not predict other educational beliefs or values. An example, interest, usefulness, and perceived ability. So a lot of times, economically disadvantaged students tend to have a perception that math does matter. It's something that's practical and useful, but they kind of think of themselves as, because they're disadvantaged, they tend to think that, well, it's just not something I can learn. I don't have the resources, and so I'm just not going to be good at it. And that's damaging thinking in the long run because it prevents their achievement. So an analysis of data related to parental background found that family income was indirectly associated with children's math school readiness and numerical support. Higher income predicted greater numerical support, and in turn, greater maternal numerical support predicted higher math school readiness. So students that were economically advantaged did come in with just a higher readiness because they have resources at home where they can learn. A lot of economically disadvantaged students do not have the same opportunities to learn math before they get into education, be it public education or just what you get at home from your parents. There's a major difference there. So economically advantaged students do have an advantage starting out, but this doesn't necessarily mean that economically disadvantaged students are starting out with anything that's an obstacle other than their perceptions. And that's why perceptions are such a major problem in math achievement, and in turn affect that cyclical economic success. So this is why we see a cycle of economic success from math achievement. So if research indicates math achievement as a predictor of economic success, and it indicates economic success as a predictor for math achievement, but it demonstrates low economic success is not a preventative of mathematical ability, what effects produce cyclical outcomes? One of the first places your mind might go is, well, is it just student potential maybe? If there's not an obstacle, a concrete obstacle to students learning, is it just that certain students have better cognitive potential? Is that the issue? That some students are just better, and so naturally they tend to make more because of that cyclical success in mathematics and the ability? But if we look at cognitive research, it seems to dispel that. And I don't want to be definitive here. A lot of this is examining correlation versus causation. A lot of research has not established concrete causation, but we can draw from all this correlative information that thinking the other way, that it's just a predetermined brain structure that allows you to succeed, doesn't seem true. This seems to dispel that, because the developmental effects of engagement with math education radically changes our brain structure. And that can be identified from studies. A cognitive study on math instruction highlights the role of specific neurochemical, GABA, in education during adolescence, its association with brain connectivity, and its capacity to predict future math ability. The research found lowered ability was associated with a lack of further math education during adolescence, which could be predicted by GABA concentrations. So to break that down, there is a neurochemical present in our brains that scientists can examine, and they can find it present when we're doing math. And there's also a difference in concentrations depending on the level of education in adolescence. So that just being in education itself radically changes how your brain is producing chemicals that are vital to performing the skill of math itself. Another group of researchers tested a system of identifying math and non-math students through MRIs, finding their analysis of brain matter could differentiate a same age group of 51 non-math students and 72 math students with an accuracy of 90.24%. And granted, these were 16-year-olds. So before they examined adolescents, this is further down the line, 16-year-olds who chose to either continue with their math education or to drop out of that. Distinction demonstrates the effectual relationship between math learning and brain structure. A scientist can go and scan your brain and then predict with a 90% accuracy rate whether or not you are currently undergoing math education or not. That seems to demonstrate that the education itself, participating in that learning, radically changes the structure of your brain. So, in conclusion, research presents a strong bias towards achievement in math education, predicting economic success and cognitive development, thus cementing math education's utility for everyone. And that's why all of you should, I hope after this, really be invested in this presentation on what your children, what your relatives are going to be learning in schools now and in the future, and comparing it to what we've seen in the past. So I'm going to hand it back over to Morgan, and we're going to see what those perceptions look like from all of you.
How do we get students to like math? That is a great question, and I found from an article from News Mechanism of Rockridge, it states nearly twice as many students, 46%, reported that they love or liked math compared to those that said they hate or dislike math, which was 24%, and everyone else was indifferent about the subject. I don't know about you, but in growing up in like classes now, most people say that they do not like math. They say that math is hard. They say math is their least favorite subject. So we wanted to take a survey to kind of see if that matched with what we hear and like our research. So looking at the data, we surveyed for about 7 days. We had 56 people respond to our survey, and there were 60% of people said that they do not like math. There was 39% that said that they do like math. We asked about math anxiety because that can relate to why some people may struggle in math. And we found that there was 46% of people said that they do have math anxiety. 42% said that they don't, and 10% said that they were unsure. We also asked about gender, because that can relate to stereotypes and why people may not like math. And we had 58% of female say that, or take the survey, and 39% of males took the survey. And with that being said, gender is one reason why math, people may not like math, and it could be the stereotype that boys are better at math than girls. And when it comes to like math games and competition, boys tend to be more competitive, and some students may need more time to work out problems. So in a high intense situation, like that could cause like the slower workers to not be able to answer as fast. And there were 2 gender differences, which is self-concept and intrinsic motivation. Self-concept is how we perceive our behaviors, abilities, and unique characteristics. And intrinsic motivation is doing something that you like when it's not required. And in this study, they have found that female students had a fixed mindset in math, which was associated with not only a lower ability of self-concept, but they also had a low intrinsic motivation. So both of those gender differences are very low, and we want to increase that, especially for females, since they may have like thoughts of if boys are better at math, then they just may not have the motivation, or like they may have low self-esteem for math. And we also found that only 28% of women work in STEM fields, and that includes science, technology, engineering, and math. So we want to see this number increase of women working in math careers. Boys also tend to jump to answer questions faster than girls, so just providing them equal opportunity in the classroom, or if you're working with a group of students, giving them the same amount of time so they all have equal time to answer. Another reason why people may not like math is math anxiety, and this is defined as feeling of tension, apprehension, or fear that interferes with their math performance, and this can be linked to not wanting to learn math. And if you're a teacher that has math anxiety, you don't want to show that to your students, because that can feed off to your students and then they can feel anxious. And math anxiety is different than test anxiety. And I found a study that had 2 different training to try to figure out what was better for math anxiety. The first one was math anxiety training, which had recognizing your emotions, breathing exercises, and how math was important to the world. And then the math strategy training was more of spoken and written skills for math and accuracy and speed. And they had found that the math strategy training lowered math anxiety, but it also improved and increased your math ability. So if you're working with students, working with them on spoken and written ways to calculate addition, subtraction, multiplication, that will lower their anxiety more than like calming techniques like the anxiety training. And then the next and last reason why some people may not like math is motivation. So if you don't have motivation to do something, you most likely are not going to want to do it. Motivation also leads to learning difficulties or maybe not wanting to learn something. So if you don't like math, you probably don't have the motivation to do it. And if you're a teacher or someone working with students that don't like math, try to have a positive attitude and show excitement, because your excitement and feelings will feed off to your students, and then they will feel more excited to do it. And I have also found that if you're a teacher and you don't like math, don't let your students know that, because then they know it's okay to not like it, which it's okay to not like math, but when they're young, you want them to like every subject as much as you can, because learning is important and we want them to like every subject if possible. And then I found some ways that can help motivate learning, which include math games, connecting math to real world problems, using manipulatives and technology, providing rewards. Right now, there's really popular dojo points in elementary schools. So if they got something correct, you could be using dojo points as like a reward. And then I found this Go Fish Pretend game. These are the directions on how to play, but a little quick summary is you have a deck of cards, and the students are looking for combinations of tens. So this is good when you're working on the number 10 or like adding. So each kid will have 4 cards at all times. So when you deal them out, they'll have 4 cards. They'll find pairs if they can. And then if they found pairs, they're going to draw some cards that you have 4. And then, for example, if I had a 4 in my hand, I would ask someone in the group if they had a 6. And if they did, then that's great. I have a match. And then if they do not have a 6, I would have to go fish. Which would be a fun little activity for kids to do on their own or as like a whole class. And then lastly, I have a bunch of pictures of different manipulatives that I've used over the years. The geoboard, counting bears, fraction tiles, base 10 blocks, Unifix cubes, counters, and shapes. I'm sure you have seen some of these growing up. I know we use shapes a lot. When I grew up with Unifix cubes, we're using them now in our class, and they still help me solve problems. But manipulatives can help students solve maybe difficult problems, or if you have visual learners, they're able to visually see how they solve a problem or how they got to their answer. You can also use drawing as a manipulative. So if they have like their math journal, you can have them draw out their work, and that can also help. I'm a visual learner, so using manipulatives definitely helped me. So even if you don't have visual learners, just using your hands and being hands-on in math can help. And now that we like math, we're going to learn how math has been taught and changed over the past 10 years.
Okay, so think about where you were 10 years ago. In case you were wondering about the pictures, that's Morgan, Lakin, Austin, and I 10 years ago. And as you can tell, a lot can change during that time. In 2012, we were all dancing to Gangnam Style, singing along to the Call Me Maybe parodies, watching the first Hunger Games movie. And for all of you Gossip Girl fans, we figured out who the true Gossip Girl was. So think about how much you have changed during this time period. Think about how much the world has changed, and now think about how much math has changed. That's something that people don't normally think about. And since we didn't stay in the same classroom, it's kind of hard to imagine the difference between the curriculum now. I mean, math is still math, right? And the way that we learned has to be the correct way. Wrong. There is no correct way to teach. There is a way to make sure that students understand what they are learning. So 10 years ago, Lakin and I were in 4th grade and Morgan and Austin were in 5th grade. And during my time in 4th grade, we were learning all of the normal 4th grade stuff, multiplication, division, fractions. And while I was learning how to do all these things though, I was learning how to do the algorithm. And that is a problem that was seen all over the country during this time. And teachers were more focused on how to get from point A to point B the quickest. They were focused on their CRCT and milestone scores, and they wanted students to memorize the algorithm so they could perform well on the test and do it quickly and answer all of the questions. So once the test was over, it didn't matter if we remembered how to do the algorithm or not, because we had performed well on the test and had gotten through all the questions because we knew how to do it quickly. So, but the blame was not all on the teachers, because this is just how math was taught everywhere. There was a study done on 1st graders in 2012, according to Developing Changes in Working Memory, Updating, and Math Achievement. And it said that others suggest that math performance is dependent largely on building up domain-specific skills and knowledge. So this means that when 1st grade students were asked to solve a problem, they could do it through algorithm, but when they were asked why one thing equaled another, they could not make a relationship to answer why. So the American Teacher Panel also gathered data in 2015, and during this time, 2,673 teachers' classrooms were examined. And the results were actually very surprising. Only 31.54% of students were able to apply or connect math topics they were learning to a real-world situation. 18.82% of students used hands-on tools to explore mathematical ideas or to solve problems. 23.57% of students explained their thinking about mathematical problems. These statistics come from the article Day by Day Investigating Variation in Elementary Mathematics. And if you think about it, all of the statistics that I just read off are under 50%. Less than 50% of teachers were using real life concepts, visualization, and in the same article, the author also stated a much smaller percentage of teachers reported spending a considerable amount of instructional time reviewing in conjunction using hands-on tools or ideas to solve problems. And this will not shock you. Only 3% of teachers used hands-on materials in a math classroom during this study. Out of 2,673 teachers, only 3% of them used hands-on materials. So this is crazy to think about, because the algorithm meant much more to education than helping students understand what they were learning. And they were also not being taught about the visual aspect of math and how to visualize what the numbers look like in their head, and be able to create estimates of what different values look like. And now teachers are being geared towards real life application and teaching why one thing equals another to students, or why one thing multiplied or divided by another thing equals the answer. A fraction, it's a part of a whole. You don't just have to flip the problem to get the arithmetic answer. The main goal of teaching math now is to have students understand what they are learning, and they are learning more than an algorithm. And by doing this, students are prepared to learn more in-depth concepts in the future. We are now preparing our students in younger grades to have a concrete foundation in math by teaching them the why part of it before we're teaching them an algorithm. So honestly, I did not understand percents until my freshman year of college, which was last year. And So when I went shopping, I could only use the algorithm to take off a certain percentage for a piece of clothing that I wanted. And my mom actually had to explain to me what it meant to take a percentage off of the clothes. So, and there was a study done in the article, Emergence of the Link Between the Approximate Number System and Symbolic Math Ability. And in this study, students between the ages of 3 and 8 were tested on addition. Some of the students learned addition through the algorithm, and other students used hands-on materials and visualization to learn addition. And when they were tested, the students who used manipulatives and visualization scored an average of 75% correct, while the students who were taught the algorithm scored an average of 69%. You may not think that that data is very different, but for averages on a test, that's huge. That's 75% correct versus 69% correct, which means there are scores lower and higher in that area, but the average were those two numbers. So now teachers are beginning to help students learn how to visualize problems. This is easier for students to do when they have a problem that they've seen in real life, or it's something that they could see in the future. In the article, Implementing the Common Core, Applying Shifts to Instruction, students were given a problem about a pet store wanting to build new units for their small dogs. This is a problem that the students could see in real life, because more than likely all of the students had seen a small dog at some point in their life, and they could see how big a unit would need to be for this small dog. They were given the dimensions, and they were trying to figure out how many units for small dogs could fit in a new building. The students were put into groups and given poster paper so they could write out their thinking. And most of the students actually ended up drawing the units and how big the dimensions were. And this helped them figure out how much space each unit took up in the new building. Once all the groups had an answer for the problem, the teacher called up 3 different groups that had presented their information in different ways. And she made sure to call up one specific group because they had drawn out all the different small units, and they realized that they were just adding 3 feet for each unit. So the teacher decided to showcase the strategy, because if other students were struggling with this problem, this method would have supported those students in developing their understanding. This example is important for us because because the problem is helping us use real life problems, and the students visually worked it out by drawing, and the teacher helped the students justify their answer and helped struggling students by showcasing this one answer with drawing in it. I also found in the current article, Teaching Pre-Service Teachers to Make Digital Stories That Explain Complex Mathematical Concepts, that when pre-service or new teachers became aware of the relationship between visual representation and the critical thinking process, they saw, and they implemented it in their classroom, they saw a jump in student engagement, motivation, and their overall understanding of math. So this being said, you may still have a few questions about what really is the difference in the way that we were taught and how teachers are implementing the curriculum now, and Lakin is going to show you a few differences.
So I'm going to talk about the misconception of new versus old math, and a basic definition for new math is the way students are manipulatives or visual concepts. And the way that math has been presented has changed a lot over the years, but educators and educators, parents, and students all need to be on the same page when they're discussing math. So the term new math versus old math is being used to discuss these different ways of working math problems. However, it's becoming problematic at home when parents are sitting down to do or help their children with their homework or other math activities that they've sent home. And one way to prevent the confusion is to send side-by-side comparisons of the same problem, just worked in different ways. So one example should show like how the students are learning to work the problem in class. And then the other example should show a former representation of maybe how it was worked out 10 years ago. And then parents, educators, and students need to understand that math is math. There are just multiple strategies and techniques to solve the math problem. In the next few slides, I'm going to show you 2 different examples, and they're just going to be worked in 2 different ways. So here is example 1. It's a 3-digit subtraction problem with regrouping. And one of the common ways that students are learning to work these problems in the math classroom today is by using base 10 blocks. And so you can see that picture, and then this is the actual manipulative. And in base 10 blocks, 100s are called flats, 10s are called sticks, and 1s are called singles. So the problem that we're trying to work is 353 minus 176. So for students to start this problem, they would lay out the 353, and then they know they're going to have to take away 176. So their first step would be to take away a flat or 100. Okay, and then the students know that they're going to have to regroup. So you would break a flat into 10 sticks, because 10 sticks equals 100, and this is a trade. So we're going to trade this for 10 sticks. So far we've only taken away 100, but we still have to take away 76. So now that we've broken this flat into 10 sticks, we're going to take away 70, because each stick equals 10. So 10, 20, 30, 40, 50, 60, 70. Okay. So now we've taken away 170, but we still have to take away 6. So we're going to regroup again. So to do that, we're going to have to break another stick and trade it for 10 ones. So we're going to add our 10 ones. We only had 3 singles, and that's why we had to break the stick. So now we have 13 singles, and we're going to subtract sticks. So 1, 2, 3, 4, 5, 6. So now your remainder is going to be the answer to your problem. So we have 100, 10, 20, 30, 40, 50, 60, 70. And then 1, 2, 3, 4, 5, 6, 7. So the answer to our problem would be 177. And this way of working the math problem relies a lot on place value. So now we have the same 3-digit subtraction problem, but this is how you would work, or how students would work it using standard form. So a common phrase when teaching regrouping is more on the top, no need to stop, more on the floor, go next door and get 10 more. So to solve this problem, the students would work from the 1s place to the 100s place. And on our first, in the 1s place, the 6 on the bottom is bigger than the 3 on the top. So you have to go next door and borrow 10. So you add your 10 to the 3 and you get 13. After you do that, you can subtract straight down. So 13 minus 6 equals 7. Okay, so then we're going to move to the 10th place, and your bigger number is still on the bottom, so you're going to have to regroup again. So you would go next door and you would actually borrow 100 from the 100th place, because this is in the 10th place, so this would really be 140, and then it would be minus 70, and more this right here. So 140 minus 70 equals 7. So then you're going to go to your 100th place, and you have a bigger number on top, so you can go ahead and subtract straight down. So 2 minus 1 equals 1, and your answer is still 177. And you can use standard form to check how you work the problem using manipulatives. Okay, so this is example 2, and it's a whole number operations problem, specifically working on equal groups. And the image on the board is a pictorial model representation. So the word problem is, at a party, there are 15 pieces of bubble gum left to be shared fairly among 5 children. How many pieces of bubble gum would each child get? So to solve this problem, the first thing the child would do is look at their word problem and see what was given to them. So the students know that they have a total of 15 pieces of bubble gum and 5 children who each need to receive the same number of pieces. So the first thing the student could do would draw out their pieces of bubble gum, so they know that's their total, and then draw 5 circles to represent the 5 children. Then the students would go and one by one place a piece of bubble gum in each circle until they ran out of pieces. And after they've done this, the student would conclude that each child would receive 3 pieces of bubble gum. Okay, so this is the same word problem, but we're solving it by using an equation. So the word problem is, at a party, there are 15 pieces of bubble gum left to be shared fairly among 5 children. How many pieces of bubble gum would each child get? So again, they would look and see what was given to them in the word problem. So they know they have 15 pieces of gum, which is their total, and they know they need to be divided evenly among 5 children. So 5 children is your equal groups. And then so 15 divided by 5 equals 3. So they know that 3 would be in each group. And if the child wants to check their work, they could do 5 times 3 equals 15, or they could skip count by 5s. So in conclusion, conceptual learning in mathematics focuses on teaching math by concepts instead of asking students to memorize specific facts, formulas, or methods for working problems. Math concepts are the why in relation to solving math problems. And then teaching conceptually allows the student to understand mathematical ideas and apply them to other problems or new contexts. Math is math. There's no new math or old math, just simply different ways to find solutions to the problem. And the difference seen in today's classroom is the focus on students' ability to explain their reasoning behind the answers that they got for their problems. And here are